I'm Dr. Stephen Fenton, pediatric surgeon and director of the Grant Scott Bonham Fetal Center at Primary Children's Hospital in Salt Lake City, Utah. Today, I'd like to talk to you about congenital lung malformations, sometimes referred to as CLMs. No one really knows the cause of these lesions in the fetus. However, they take on several different forms. Some are called bronchopulmonary sequestrations, or BPS. Others, congenital pulmonary airway malformations, known as CPAMs. Congenital cystic adenomatous malformations, or CCAMs. And a combination of the three, also known as a hybrid lesion. Each of them have distinct characteristics, although really you can't tell what it really is until after the child is born and it is removed. We actually see and take care of many moms whose fetus has this condition. And we follow them closely for a period of time, usually with ultrasound. Now, these lesions tend to be found on the initial screening ultrasound, and some can be small and others can be large. They do continue to grow quite rapidly up to around 28 weeks of gestation, at which point the lesion's growth slows down while the fetus's growth continues to increase. We do a measurement by ultrasound called CPAM volume ratio. It measures the volume of the lung lesion and divides it by the circumference of the child's head. So we're able to actually use this throughout the duration of pregnancy to monitor its growth. Now again, the CVR will increase up to around 28 weeks of gestation, at which point it plateaus, and we typically call that the maximum CVR. At that point, we oftentimes see it drop. When the lesion is large with a high CVR, it can actually cause compression on the heart, and that's what leads to heart failure. Heart failure is seen when there is fluid in spaces of the child that there shouldn't be. For example, around the heart, around the lungs, in the abdomen, or in the skin. We call this hydrops when it occurs in two or more of these places. And this conveys a serious risk to the baby, warranting therapy. Luckily, most of the children we care for here do not develop that. Now, if a fetus does have a CVR greater than 1.5, we would implement treatment based on the type of lesion that it is. For large microcystic or solid lesions, maternal steroids are the first line of treatment. Moms receive 2 doses 1 day apart, and it is shown to decrease the size of the lesion or halt its growth, allowing hydrops to resolve, or helping the child get closer to 28 weeks, where hydrops will resolve once the CVR begins to come down. In some cases, it will allow the child to be delivered closer to term. Another type of treatment for the fetus who has a CVR greater than 1.5 is what we call shunting, or a thoracoamniotic shunt. This is typically used in children who have a large cyst that can be drained. So under ultrasound guidance, a tube or shunt is placed into the cyst that then drains out of the child's chest into the amniotic cavity, hence a thoracoamniotic shunt. This typically allows these large cysts to decompress and stop putting pressure on the heart, which allows the heart failure to resolve. We typically have to put more than one shunt in children who have a large cyst, usually over a period of time, because the shunt becomes clogged or it's pulled out by the fetus. However, most of the time, placing the appropriate shunt will allow these babies again to get past 28 weeks and for us to be able to deliver them much closer to term. Now, luckily, as I said, most kids do not require treatment while they're still in the womb. So that brings us to the next value of CVR. It helps us determine how sick or symptomatic the child will be once delivered. And this is really conveyed by the maximum CVR. And I break it down into 3 different groups: less than 1, 1 to 2, and greater than 2. Let's talk about CVR greater than 2. These lesions are typically large, compress the heart, or push on the heart structures to the other side of wherever the lesion is, and typically result in underdeveloped or very small lungs. These kids will oftentimes have symptoms after delivery, needing help to breathe with either a ventilator, oxygen in the nose, or oxygen get delivered through the mouth and nose. Therefore, we have our moms whose child has a CVR greater than 2 deliver in center here for immediate subspecialty care. The NICU doctors typically help the child breathe, again with assistance as needed. And in most cases, those kids will require surgery within the first week of life, typically through a larger incision called a thoracotomy on the side of the chest where the lesion is. They typically will then stay in the hospital for several weeks afterwards while their lungs continue to grow. Most kids, though, do very, very well, and once they leave, recover. Now let's talk about children with a CVR less than 1. Those kids are typically born and don't even know they have the lesion. They pink up and breathe like a normal newborn. They're able to feed without difficulty and oftentimes meet criteria to go home with the mom when she's ready to go home. These kids we typically see about a month after they leave the hospital, oftentimes by Zoom, just to make sure they're gaining weight, eating appropriately, and breathing without difficulties. We then have them come here and get a CT scan of the chest to evaluate this lesion, mainly because we can't see it any further on chest x-ray or ultrasound once they've breathed air into their lungs. That CT scan helps us plan for surgical resection, and most often these kids can undergo minimally invasive removal of that lesion through 3 small incisions the size of my pinky. They typically stay in the hospital 1 to 2 days and go home and are seen about a month later, most of them very well recovered by that time. Now, the children with maximum CVR between 1 and 2, they can act either like those with a CVR less than 1 and those with a CVR greater than 2. So we typically have them deliver here in the center for observation. We want to make sure they can breathe accordingly and eat accordingly. Some of them may require supplemental oxygen through the nose, and others require assistance with feeding through a feeding tube. In any case, most children with a CVR less than 2 will be able to undergo surgery around 4 months of age, again through the small incisions, typically requiring 1 to 2 days in the hospital following the procedure. Maternal steroids and shunting have really made fetal resection of these lesions incredibly rare. I never say never, and it's not 0%, but most kids are able to be treated who have high drops by steroids and or shunting, and get to the point where instead of fetal resection, they may undergo what we call section 2 resection, or immediate C-section of the mom to deliver the child. The child is then resuscitated by our NICU team and undergoes immediate thoracotomy with resection of the lesion. This doesn't happen often, but we've seen kids with large enough lesions and compromise of their heart that we have had to do these procedures. Rarely is an exit to resection required. This can actually lead to increased morbidity for the mom, especially for subsequent pregnancies and for long-term reproductive health. We try and avoid these if necessary, but do have the capabilities to do so if we feel like it is safest for the baby. However, most of our severe lung lesions can either be treated with steroids, a shunt, and section to resection. So in summary, we care for a lot of congenital lung malformations here at the Grant Scott Bonham Fetal Center at Primary Children's Hospital in Salt Lake City, Utah. They take all shapes and sizes: bronchopulmonary sequestrations, congenital pulmonary airway malformations, congenital cystic adenomatous malformations, or a hybrid of the above. We follow our moms closely with ultrasound, measuring the CPAM volume ratio, or CVR, throughout pregnancy, which helps us guide whether a child needs intervention while still in the womb, such as steroids or a thoracoamniotic shunt, or how symptomatic the child will be upon delivery. For more information, please feel free to reach out to our center directly on the contact page of this website. We'd be happy to get back to you and answer any questions you might have.